Hey, everybody, welcome back to the Monday Afternoon Journal Club. Ed Bowder and Dan Schwester here. Danny, how we doing today?
All right, man. How you doing today?
Just trying to plug away while the world is slowly more and more on fire, man. So today we have a really, really cool paper that comes out of Australia. This is
Mhm.
Doveti et al. Coming out of Resuscitation. Dan, they did this is a review, so this isn't clinical data, but really, really important study, I think, that came out earlier this year.
Mhm.
So what this looked at was they wanted to examine global variation and incidence in the outcomes for EMS that attended and treated out of hospital cardiac arrest from initial asystole.
Mhm.
So where this is going to contribute to our literature is this is saying how many patients are initially asystolic and how many, cardiac arrests do we first get to where they're in a flat line. This is also a global perspective, which is very interesting because it's not just the United States, it's not just Sweden, it's not just the UK.
Right.
And, they looked at 4,464 articles. They included 82 studies, 540,000 patients in
Wow.
this actual analysis once they went through it. So huge, huge, huge. And obviously with that type of sample, there's a lot of variability. There's a lot of different things that we can know, but their conclusion, initial asystolic out of hospital cardiac arrest made up 53% of all EMS treated patients, and
Okay.
pooled survival rates were extremely poor. Research efforts in this population should focus on developing prevention strategies as well as adherence to termination or withholding resuscitation guidelines for asystolic out of hospital cardiac arrest. Dan, all the stuff that we love in data. This is a huge, huge meta analysis, really great. And they talk about what the problem is. They say more research is needed. And
Mhm.
there's not a lot that's already extant on all this stuff about cardiac arrest data, but really, really interesting. 53% of initial out of hospital cardiac arrest
Yeah.
is asystole. So it's bringing up the question that we've been asking both on the show and in the profession for a while. What are we doing for cardiac arrests?
It's your favorite question.
Yeah, it's
Um,
what are we doing? Why?
I think again, this is going back, and we've had a few discussions on this topic in various ways over the last year or so.
Sure.
I think, listen, it's not even like we're quoting an underpowered study here. I mean, you got
No.
500,000 entries. This is not underpowered.
Hmm.
What we're seeing is that over half of them are pretty much asystolic, and the survival rate is pretty abysmal. Now, remember, worldwide study, your
Right.
pre-hospital care in your town is not what you're going to see in Tanzania or Paris or,
Yeah.
Prachi
Well,
or
and
wherever.
we've said if you see one EMS system, you see one
Correct.
EMS system.
Correct.
Yeah.
Absolutely. But the reality of this is over 53% of these people are presenting in a preterminal rhythm,
Right.
and our survival rates are not increasing. Who survives cardiac arrest? Generally younger, generally healthier, generally a coronary artery lesion that is easily
Right.
corrected. If we can get
Witnessed.
them alive to the cath lab, that means a
Yeah.
lot of things have to come together. You have to be witnessed. You have to have somebody there to get on the chest. You have to have a good 911 system. You have to have first responders. You
Yeah,
have to
you
have
have to have
rigs,
electricity. You have to have an AED that works. You have to have a dispatch center
advanced
that
care.
sends you appropriate. Yeah, it's
So
all
many
of it.
things have to come together. Okay. Even in the worst places in the United States, we are way better than some of the other poorer nations around the world.
Sure.
That being said, I personally feel, and I'm starting to believe this, and I don't know if this is popular or people are going to like this. I'm going to tell you that I think that asystole is a preterminal rhythm. And unless you have an immediately reversible cause, this is somebody who has died. We are not going to be able to get them back. Where we need to
Yeah.
do the work is identifying people who have the best chance to survive, giving them the resources that they need, identifying people who are already preterminal or who are in the process of dying actively, and allow them, allow that to happen and have
Right.
some dignity, not torturing their body, not dealing with the moral injury of always going on these calls and coding these very frail, very elderly people with irreversible
Yeah.
cardiomyopathies and irreversible, end of life
So
issues.
I wonder in these studies. So it also showed that only about 16% of patients had ROSC and about 1.5% of asystolic arrest had any survivability at 30 days. So we talk about like what's effective, what's ineffective.
Right.
I think that we have this very, and maybe it's necessary, a puritanical view of life and death. And, we should, I'm not taking away from, life being important and sacred to people and whatever. I think that there's sometimes a reality that we have to come to where life is a terminal condition. And I almost wonder, and so this is where it gets hard, right? Because this is where you have the emotion and the human condition overcoming the clinical data, right? If you go into a cardiac arrest and you tell the family, like, listen, only 1.5% of people survive these cardiac arrests, that's not
They're
going to be a
gonna
good enough answer for that.
No, and if you give them any hope at all, they're gonna say, "Please save my do it." Any
Right.
chance there is to save somebody, you do it. And I don't think
Yeah.
that's wrong, but I think we
No,
need
I,
to
I don't
change
think,
I think we need to change our focus here. I think we need to be able to be better at identifying, and this means giving us tools to identify. I want to identify that unwitnessed arrest, the Opal's
yeah,
criteria patient who, we know. And you know what? Give me an ultrasound. Let me put it on the chest. Let me see no heart wall movement. Let me see cardiac standstill.
right. Yeah. Give me
And
something to confirm it. Yeah.
we're good here. Like we can be very good as EMTs and paramedics. What we are
Mhm.
not good is resurrection or
Well,
saving a
what's
life that's
interesting,
already passed.
what's fun in this is like out at the Medic One project in King County, they've been pronouncing asystolic arrest for years, and their VFVT numbers are great. It's over 50%
Mhm,
every year. I think people are kind of blown away when they see that data point out of Washington State, and I
mhm.
nothing but love for those guys.
Oh
That's
yeah.
not the issue, but if you're looking to it's almost kind of like you have to go to where the people are, right?
Mhm,
Like if you're looking to improve your cardiac arrest survivability numbers, you have to go to where the survivable cardiac arrests are.
mhm.
Where going into a scene, it's great if you want to sit and you want to follow AHA. Great, go on in, 20 minutes, give them 3 epi because the paperwork tells you to. But those patients are still going to end up being pronounced, right? And there's a whole bunch of data on conveyance versus non-conveyance.
99.999% of that. Yeah.
Yeah, well, literally in this 99% of the time, they're going to end up being pronounced in the
Mhm,
field. So where this conversation is important, and again, this isn't novel data. This is just a review. So we
mhm.
always ask when we're doing these journal clubs, what do we learn? What do we take away from all this? What's who cares, right? What's the value? This is the kind of information where systems can really take this and say, okay, we can change how we actually approach
Yeah.
cardiac arrest, right? Where you can improve outcomes, you can have, better patient outcomes, a better, provider patient interface, and you can kind of accept the reality of the world we're living
Mhm.
in, right? Where I think
And
that,
and if we
good.
had more training and understanding, we could convey that to our families of our patients so that
Yeah.
they didn't have that shocking, "Oh my god, they're not gonna live like I saw in Chicago Med or the Pit or
Right. Yeah.
whatever."
You're not
You
going to
know
immediately get up and walk away.
exactly. I'm
Get all
not
those
saying
Lazarus effect
listen,
patients.
absolutely. I'm not saying that we shouldn't keep life sacred and that we shouldn't protect it and try to keep it at all costs. What I'm
Right.
saying is we need to stop with the idea of these perfunctory, futile resuscitations that do nothing for the patient, have no benefit for the patient. There's no
Right.
benefit for the people who are trying to provide the service, and there's no benefit for the family here. No one gets better from this.
Yeah, and I think that's the biggest thing is, and maybe there's a value to, pastoral training, that kind of thing, where you can go in and say, like, listen, this is whatever the better way to approach the family would be. That's all kind of outside of the scope of this paper, right? Where, and I think that's another thing that we do is, this is what this data say, and they're like, well, what about this other, non-controlled variable? And I'm like, okay, well, 99% of
But
your patients in asystolic cardiac arrest don't survive. That's the important thing to come
right.
out of this.
But Ed, let me put it to you this way. Data like this and papers like this help drive discussion, and they help
Yes.
drive discussion towards okay, now we've got 500,000 cardiac arrest patients with a 1% survival rate in a
Yeah.
systole. And I bet you if they I bet and they didn't do this in this paper, but I bet you if you stratified them out and figured out why, they were not what you would expect. Those were the impact apnea, traumatic arrest, motorcyclist
Mhm.
into something that you get there, you bag them, you decompress their
Yeah.
chest. That's a clean save. We're not talking about that. We're not talking about giving up on viable patients. What we're
Right.
talking about is realizing that for most people in this situation, cardiac arrest is a terminal event. That is the
Yeah.
end. Everybody dies from cardiac arrest in the end because that's what happens. Your heart stops, and that's the ball game.
Yeah, and it might be that as a profession, we have to kind of start accepting that and maybe using that to guide our treatments. But we want to know what you guys think. How do you feel about almost every asystolic cardiac arrest around the world end up being a pronouncement? Let us
Is
know.
Dan completely heartless? Let's find out.
Do we all have no souls? Comment. Let us know down in the comments whether or not we have souls. Be sure to subscribe here on YouTube and check out the podcast. Check us out on EMS1 and for the Overrun and Monday Afternoon Journal Club. Ed Bowder and Dan Schwester, and we'll talk to you all next week.